In my presentation, I will also talk about the transosseous suture repair of massive rotator cuff tear, covering the talk of Dr. Kovac. Recurrent large and massive rotator cuff tears after an open or arthroscopic reconstruction is a difficult challenge to the surgeon because of bad quality of the tendons and bone anchor space taking. Many publications on treatment of massive rotator cuff tears with good results are reported, but to my knowledge, no publication on arthroscopic treatment of failed repair of large and massive rotator cuff tear is presented. Recent trend in treatment of massive rotator cuff tear is the implantation of reverse total shoulder replacement. Some surgeons even do the replacement with a joint without osteoarthritis when the clinical findings of weak or loss of active elevation and external rotation, as well as an MRI finding of massive tear is present, without evaluation of the possibility of rotator cuff reconstruction. Arthroscopic, I think there must be standards for decision making in treatment of massive rotator cuff tear. So we use arthroscopic standards to know the type of treatment needed based on arthroscopic preparation of the rotator cuff and two-test evaluation. We do a mobilization of the rotator cuff and capsule release between the glenoid and the rotator cuff, as well as the inferior capsule. Then we test the lateralization of the supraspinatus to reach the barefoot area of insertion by pulling it with a hook with the arm in 30 degrees abduction. So if we reach this point, then it is a positive supraspinatus pull-out test. The other test is the possibility of pulling the subscapularis and infraspinatus with a hook upwards. We test that with a hook to see if it can cover or assist the supraspinatus tear. This we call the tendon transpositioning test. If these tests are positive, so we go for an arthroscopic repair. If the arthroscopic repair is not possible for any reason, say surgical skills or not availability of equipment, then we recommend mini open repair or open repair. If the tests are negative, we recommend a reverse total shoulder replacement. If this is not possible, then we can do an arthroscopic palliative anterior acromioplasty. As mentioned by my colleagues before, it may some relief of pain, but it will not affect the function. Synthetic patches are also used recently, and this will be also discussed by my next speaker, Dr. Oma. The technique of reconstruction of large and massive rotator cuff tear is targeting a reconstruction of a supraspinatus for head stabilization during elevation. We divide these techniques into three types: the basic reconstruction, the bicep assisted reconstruction, and the tendon transpositioning. Basic reconstruction of a large U-shaped tear, the repair steps is a side-to-side suture to develop a margin convergence as described by Burkhardt, and then the prepared margin is transosseously fixed to the bone. The reconstruction of a large L-type tear is by finding the apex of the L-type and pulling it anteriorly to see at which point we want to suture it. And at this point, we pass a suture through the bone so that we can pull the suture through the tendon using a chop needle puller or any device, and then tie this end to the bone. After that, we do the transosseous suture fixation of the rest of the tear and the end-to-end suture repair. Now, reconstructing of infraspinatus large tear associated with massive tear is done by the same way, pulling the upper end of the infraspinatus upwards and finding the point where we want to suture it. At this point, we pass the suture through the bone, and then we pull the suture through the upper end of the infraspinatus tendon. So we suture it and fix it here up. Afterwards, we see if there is any larger tear downstairs. We can suture it with so-called transosseous humeral matrix suture repair by passing the suture with K-wire through the bone and tying two sutures anteriorly to make a matrix repair. In case of subscapular tear, the same technique is used, but here we have to avoid to do the suture below the biceps tendon if it is present. And transosseous matrix suture is done if it is needed. Now, the biceps assisted reconstruction, this technique, we lateralize the biceps, we remove it from the sulcus and do a bicep tenodesis laterally so that the biceps is in the middle between the infraspinatus and the subscapularis. And on it, we suture the remainder of the rotator cuff. And finally, we cut the biceps from its origin above the glenoid. Tendon transpositioning repair is also done arthroscopically, can be done. That is by resecting the upper half of the subscapularis, for example, here in this case, and then pulling this part upwards and suturing the lateral margin to the bone and the medial margin to the remainder of the supraspinatus. These are the instruments which I use. I use for the suture placement the giant needle, and for the pulling of suture through soft tissue, this chopped needle suture puller. Here we see how we use this needle to pass the suture through the tendon. And then pulling it out. This we call a repair complex. Here we have a massive rotator cuff tear, and the tendon is retracted to the glenoid. First, we do mobilization, as Andreas mentioned. It's very, very important to mobilize the tendons and capsularis, and then we do the test, the pull-out test of the supraspinatus, which is possible here. So we place the suture through the tendon and through the bone, and then we tie the sutures. This case is one of the cases we did for revision. Here we see the old sutures and the anchor. We remove the suture and test if the anchor is inside the bone, deep inside, so we don't have to remove it, which is in the case here. Then we mobilize the rotator cuff from below and above using shaver, scissor, and arthroscopy punch forceps. Then we test the pull-out supraspinatus pull-out test, which is then positive here in this case. And then we place the suture through the tendon and through the bone. Here we pull the suture with a chopped needle puller through the infraspinatus also. And then we pull the upper ends of the sutures out through the instrumentation portal and make a sliding knot and tie the sutures. We see here we have a complete coverage and a very good and solid fixation. We are usually faced with a problem, which is leaving a hole, in the bone after removing the anchor. This is problem of fixing the tendon in the bone. So I think in this case, the only possible technique is the transosseous suture fixation. Here we see one case which we use also recurrent. We remove the ankle because it was loose. And here, after removal, after that, we place the sutures, first end-to-end sutures medially, and then you see here the holes in the bone, and then we do a transosseous suture fixation between the holes. And here's after the suture fixation. 13 cases of large and massive rotator cuff tears out of 48 failed rotator cuff repairs were reoperated between August 2017 and January 2021. 11 of these 13 cases had a successful arthroscopic reconstruction. The follow-up was between 6 months and 40 months, the average 28 months. The average results, according to constant score, was good, and according to the American Children's Elbow Society NEAR score, was satisfactory. There were 5 males and 8 females. All cases were dominant. 85% of the cases had a double row fixation in the first surgery, and 15% has a single row fixation. 12 cases had a metal anchor, and 1 had an absorbable anchor. The average number of anchors used was 3.8 per case. The time between the first and the second operation was an average of 24 months, between 6 months and 10 years. The 11 cases were treated arthroscopically, had 1 case of an anchor removal. The other 2 cases was an infection treated with palliative treatment, and 1 case had a negative test, so they had a reverse total shoulder replacement. Immobilization in abduction brace is done for 6 weeks after surgery. We start passive motion on the first day postoperatively. The passive assisted exercises are done for 6 weeks, followed by a mild stretching and active self-assisted exercises for another 6 weeks. Then stretching and strengthening for 4 weeks, and full activity is started after 4 to 6 months. Interesting that the average active elevation improved from preoperatively 71 degrees to postoperatively 172 degrees. The average active external rotation improved from preoperatively 26 degrees to postoperatively 55 degrees. The average strength of the case was 17%, 60% compared to the opposite side. So in summary, the best therapy, in our opinion, is the arthroscopic reconstruction if the standards are available, which I mean the positive tests. If the arthroscopic treatment is not possible for any reason, as the skills are not present or equipments are not present, we recommend mini open repair or open repair. In case of if the standards or the tests are negative, we recommend a reverse total shoulder replacement. If this is not possible for financial reasons or any other reason, then a paralysis of subacromial decompression is recommended. So I can say that the treatment is arthroscopic evaluation, and after that decision what to do, to go arthroscopically, you go open, or you go in a prosthesis. Thank you very much for your attention.